we're going to go ahead and get started here today. Thank you all so much for attending this live webinar. I'm very excited to have all of you here, and it's great that we're able to offer this course in kind of unprecedented times. So my name is Eliza Is. I am an occupational therapist at Shema Kolainu-Hear. I've been practicing for 6 years. With me here today, I have Eliza and Julie, who you'll be meeting shortly. They are currently completing their Level II Fieldwork rotation at Shema Kolainu-Hear Our Voices under my supervision. And Julie and Eliza are third-year OT graduate students at DUville College up in Buffalo. So as we all know, the COVID-19 pandemic has really had a great impact on New York as a state, and even more so on our students who are mandated to receive therapeutic and other services in school. At Shema Kolainu, we spent 3 months away from the office, and while many programs were completely shut down during that time, we were able to continue services via telehealth remote instruction. New York City services more than half the children in the state for in-person instruction. So that's quite a few individuals who are really relying on that type of instruction. With being forced to move to an online platform, there was a whole host of challenges that came along with being able to provide quality OT instruction, and really a need in general of how to provide that quality instruction. So that's kind of why we felt that this workshop would be necessary to give some guidance to help individuals who are working with students in a remote location. Staff in particular really struggle with delivering engaging and developmentally appropriate interventions, and being able to partner with a parent or a guardian who's sitting alongside their child is so important for this type of learning model. Yet we're finding that many parents and guardians have varied circumstances that kind of prevent them from being an active participant in the sessions, and also that many homes lack resources and learning materials to ensure these quality sessions. There was a study done during this time by the Aspire Registry, which has information about educators and other professionals' qualifications, and respondents to this survey reported that the emotional stress of the pandemic was even more significant than any health or other financial stress that people were experiencing at this time. And this emotional component can really be a factor to a student's development of skills, and it really highlights the need for mental health services that need to be available at this time for people coping with COVID-19 and some of the situations surrounding it. And that's true for educators, for therapists, for parents, for the students themselves. So, something that we all kind of need to be thinking about moving forward. So the aim of this workshop today will go over the definitions of OT, telehealth, and we'll explore the implementation of OT strategies within the telehealth platform in relation to the pediatric population. This type of collaborative approach between school and home is really vital always to ensure a student is really able to progress in OT and really in every discipline, in teaching and in anything that you're doing when you're providing instruction. So if you think about a skill that you've always wanted to learn, like let's take piano, for example. If you only go to the piano practice and work there, let's say you go 2 to 3 times a week and you don't do any additional practice at home, how quickly do you think you're going to be able to play La Campanella, which is rumored to be the most difficult piano piece that's ever written? So it's the same thing for any therapeutic service. If you don't have the continuation and the carryover to at-home services and to at-home practice, you won't be able to make progress as quickly. So the continuation of services is absolutely necessary to really develop those skills. In this presentation, you will also learn how to use OT-based strategies and techniques in 4 main areas of pediatric occupational therapy, and learn how to practice these skills over telehealth and also on your own time. So I'm gonna go ahead and turn it over to Julie and Eliza to show us what they've come up with. So Julie, I'm gonna start with making you the host so you can introduce yourself.
Okay. Good morning, everyone. So my name is Julie Araujo. As Alexa said, I'm a third-year occupational therapy therapist student at DUville College. My current interests are working with adolescents who are transitioning into adulthood. I'm also interested in mental health as well, as I have a background in psychology. And I'm very excited for this presentation and to show you all what we've learned during this time.
I don't think I can show.
So Julie, if you want to make Eliza the host, that should allow her to also have her screen shared.
Okay.
Thank you.
There we go, guys. So I'm Eliza. Yeah, as Alexa said, we're both OT students studying at DeVille College. We're from the same cohort. So we have the pleasure of knowing each other beforehand. So this placement worked out really well for us. A little bit about me. I'm interested in animal-assisted therapy, travel therapy, and mental health. So I hope you guys really enjoy our presentation today. So like Alexa said, this is a presentation focused on using OT techniques and strategies in a telehealth format to provide services to children with autism. So to start off, we're going to define what occupational therapy is. And our goal here as OTs is to help people of all ages with a variety of health challenges to participate in daily life to the fullest. We do this through the therapeutic use of daily activities, which we call occupations, hence the name Occupational Therapy. So we typically utilize 3 services whose names vary slightly depending on the setting. First is evaluations. This is where we get to know the client, learn their strengths and their weaknesses, and what they would like to accomplish through in this case, telehealth. In this information, we can then create a client-centered goals and an intervention plan. Next is intervention. So this is the actual doing of the therapy. Here we choose specific activities that will target the area the client needs to work on to reach their goals. Lastly, we have outcomes evaluation. And here we check in on the efficacy of our intervention plan, kind of like a check-in. Here we're working to see if the interventions we have done with a client has helped them reach their goals, and if not, what we can do or change moving forward to help them get there to their goals. One of the biggest reasons I personally chose OT as a profession is that I wanted to take this holistic approach to therapy, meaning that they take into account all characteristics of a client, such as their physical condition, cognitive capabilities, mental health, and environment when creating a treatment plan. And we do this in order to maximize a client's motivation and participation in the therapeutic process. Apologies, I'm a little sick. I also wanted to differentiate before we move on, PT and OT, PT being physical therapy, as often these 2 disciplines are confused. OT and PT are similar in that both of their goals is to improve a client's quality of life, but the approach is different. PT is concerned with restoring functional mobility, meaning that they work to improve their client's ability to move and manage pain. OT is also concerned with those things, but our main goal is for a client to be able to participate in the things that they want to or need to do. So if that's a little confusing, I can take an example here. So say you have an individual with a recent shoulder injury. A PT would work on increasing the range of motion of the glenohumeral joint, meaning that they would work on increasing the amount of movement the shoulder joint has, with the goal of restoring movement to what it was pre-injury. Their treatment would be more exercise-based, reminiscent of a list of workouts you would do at the gym. OTs would also be increasing the shoulder range of motion, but only to allow them to participate in their occupations before moving on to something else. So for example, a session could be the client working on taking cans from a shopping bag on the floor and trying to put them on the table, or even better, the kitchen cabinets, or perhaps taking hangers from a laundry basket and placing them on a clothing rack. So OT-based treatment is focused on the activities that they normally do. OTs and PTs often work together. To reach the client's goals, and often client's goals are reached more easily when we collaborate.
So now we're going to speak about school-based telehealth. So specifically in the pediatric population, there's 2 different types of therapy services. We have early intervention and we have school-based therapy. So early intervention is usually done for children between the ages of 0 years old, so a couple months up until the age of 3 years old. And school-based therapy begins at 4 years old, and it can go all the way up to the age of 21. So for school-based telehealth, this is very important because it allows administrators, teachers, staff to have these conferences from remote places, and they're able to speak about what is happening with the students' progression and what are they working on daily. This is very important, especially during this time of the pandemic. All the schools in New York State were actually having remote learning, so it was very important to keep in touch with everyone. School-based telehealth also allows observation of students in their natural environments. So students tend to show different attitudes, behaviors, or skills at home versus at school. So the beneficial part of school-based telehealth is that occupational therapists are actually able to see how these students are acting at home. And usually at face-to-face interactions is more about hearing from the parents what's happening at home, but they're actually able to see what is happening via telehealth. And actually having the video conferencing is very beneficial because you can actually see the students working on these activities. It's not as though you're on the phone and you have to describe what the patient has to do. It's something that you're able to see. And you're also able to share screens with them. So this was something that we used very frequently, where we played videos and games together with the kids. And it was still a direct interaction that we had, even though we weren't face-to-face with each other. And parents are also able to facilitate their child's participation in therapy. So in face-to-face school-based settings, typically parents will hear feedback from the occupational therapist what is happening, but via telehealth, the parents can actually see what is going on in therapy and what is the occupational therapist doing to help the child meet their goals.
So now we're going to our first section of this presentation, which is activities of daily living, which we will refer to as ADLs. So here I have the ADLs listed. There are 9, and these are activities that revolve around taking care of one's own body. Like I said, there are 9. You can read them on your own, but I'm going to highlight some that we focus on with children with autism in particular. In regards to dressing, we're concerned with the selection of clothing that is appropriate for the day, the weather, and the occasion. We're also concerned with dressing and undressing in the right sequence and being able to manipulate fasteners such as zippers and buttons and adjusting clothing and shoes. For eating and swallowing, we work on being able to keep and manipulate food or fluid in the mouth, as well as being able to swallow, which is the act of bringing the food from the mouth down to the stomach. Feeding involves the setup, the arrangement, and the act of bringing food to the mouth. And personal hygiene and grooming includes things like brushing your teeth and your hair, washing hands, and trimming nails. If you have any questions about any of the other ADLs listed here, feel free to ask about it, and we can talk about it at the end of this presentation. So now we're going to discuss how autism affects a child's participation in ADLs. This goes for all sections we're going to talk about today, but the deficits or the problem areas that occur for children with autism depend on where they fall on the ASD spectrum. Autism is a broad range of conditions characterized by challenges with social skills and repetitive behaviors. So a child who is on the lower end of the spectrum would require more assistance, at least initially, and have a lower level of independence, whereas a child who is higher on the spectrum would require less assistance and have more independence. Individuals with autism present in many different ways, so the effect on their participation in ADLs is dictated by the motor and sensory characteristics that they have. But in general, children with autism usually experience a lower level of independence, increased level of assistance and caregiver dependence, and difficulty in regards to transitioning to post-secondary education or employment. So our interventions would really depend on what specific ADLs the individual is struggling with, what their strengths are, and creating a client-specific treatment based off that. Okay, so now we're going to get into some general strategies that we use when working with ADLs. However, they're not limited to ADLs and can be used for a variety of skills, but we use them a lot here. So oftentimes in the beginning of a telehealth session, when we want a client to engage in an activity, we often begin with a demonstration coupled with verbal instructions, meaning that we show the client what we're doing and narrating ourselves as we do this task. When it's the client's turn to participate, the patient or the aide or whoever is with the client or the OT from the telehealth screen will often coach the child through the activity by using reminders, like reminding them what steps they need to do or where they should be looking. We can also use pictures to show what an end product will look like or to show the steps of an activity. To talk about video schedules a little bit, these are visual prompts that are used to help predict or understand upcoming events. They use pictures to show what activities will occur and in what sequence. They can be made with pictures, written words, physical objects, or any combination of those. Just depends on what the child is most responsive to. For telehealth sessions, we'll often use mini schedules, which show the client what we will be doing for that particular session. So at the beginning of a session, we may open up a Word document filled with activities we'll be doing and in what order. For example, we'll have a picture of jumping on a trampoline, playing with a light bright, doing some writing, and then practicing dressing. And again, these are supplemented with pictures to provide that visual input. You can also use visual schedules in a within task format, which is essentially a step-by-step process of how to do an activity using pictures to narrate the task. Lastly, parents can also use visual schedules outside of therapy by using them to illustrate the activities that they will participate during any day, which is called a daily visual schedule. Lastly, for strategies that we use is video modeling. And this is where a child will watch a video of another person perform the task or skill we want them to learn. And this is a great tool because the child can use the video to practice the skill outside of telehealth sessions, and because they can replay and pause the video as needed. Next are teaching method, and techniques. We use these to teach ADLs, but again, they're not limited to ADLs, but we often use them in here. So stimulus control procedures work on identification of the stimuli before teaching the actual skill. For example, before teaching the actual skill of hand washing, which falls under personal hygiene, we would first teach them that whenever their hands are dirty or before they eat a meal, we wash our hands. And once they understand the stimulus or when we want them to perform a skill, we can then move forward and teach them that skill. Next is training and task analysis. So this is the breaking down of a complex behavior skill into smaller, more manageable steps in order to aid with the learning process. Dressing, which we will discuss more later, is a complex behavior that can be broken down into smaller tasks, such as retrieving clothes from a dresser, undressing, putting on a shirt, and so on. Instead of working on the entire task, we can focus on mastering each step one by one until they can put all the steps together to complete the behavior independently. One session could be focused on just retrieving the clothes from the dresser and laying them out in the correct order. And once they master that, we can work on the step of undressing. And we would do that with each step until the child can independently dress on their own. Lastly is prompting. There are a lot of type of prompts, but these are the three main ones we use: verbal, tactile, and visual. And we use them to remind a client or to guide them to perform a desired action or behavior. Verbal prompts are instructions or words that direct the child. It's the most common one that we use. Tactile prompts are things like pointing, motioning, or nodding toward the child or object. And then visual prompts are pictures, written instructions, or even circling the beginning of a maze to remind the child where to start. So before we move on, I wanted to note that children with severe autism will need more than just verbal guidance, and they do best when it's supplemented with physical assistance or hand-over-hand assistance. Now we're going to get into dressing, and this is a very complex skill. You need motor skills in order to move your limbs and body in the way that you want. You need fine motor skills to manipulate the clothing items and open and close fasteners. And you need perception to understand the size and shape of the fasteners, as well as navigating the sleeves, which is usually a difficult part in the dressing task for them. And you also need body schema to differentiate between your left side and your right side, and between your arms and your legs. So some general principles we're going to go over. In general, you want to have the child in a stable position when practicing the skill so they don't fall over and injure themselves. Their safety is our utmost priority. So we could practice on the floor because it's easier for children to reach their feet, or perhaps sitting on a chair or a firm bed with their feet supported. If the child has particularly poor sitting balance, they can sit against a wall or maybe in a corner so that the walls can provide that additional support that they need. When you're initially teaching the task of dressing, you may want to start with undressing first, and this is because it's usually easier than putting on the clothes. There are less fine motor skills and fewer steps involved, so that's a good place to start. You also want to follow a consistent sequence and when you're teaching this, and it can be done in two ways. First being to place the clothes in the order in which they are put on, and second being to follow the same technique for each clothing item. So when you're putting on a shirt, the steps could be to put the shirt over the head, then push the arms through the sleeves, and then finally pull the shirt down. And you would repeat this technique every single time you work on putting a shirt. And we do this because we want to be consistent, and that helps with their learning and memory process. When you're helping the child dress and you're helping them learn this skill, you want to describe the actions. For example, when pulling on the pants, you would tell the child to put their right foot in the hole and then stand up while you pull their pants up their legs. This helps them see the process in their head, and that further aids with remembering the sequence of dressing. Initially, you want to avoid practicing the skill with tight clothing just because it's harder to manipulate. Instead, it's better to use loose-fitting clothing, especially when they have a wide neck or wide armholes, just because it makes it easier for them to locate. So you could use an older sibling's shirt or perhaps your own clothes to learn the skill before moving on to clothing their size. Lastly, you want to let them problem solve. You want to allow the client time to figure out things for themselves, because that's empowering for them and it builds self-esteem, and we want that. Instead of automatically correcting a mistake, you can have the child look at their reflection in the video screen, and because we're doing this on telehealth, we'll have the video screen so they can see, and ask them if they completed the task successfully. If they need help, you can use tactile prompts such as pointing to where the problem area is. For example, if the shirt is bunched up, you can just point to it, and that itself will let them know that the shirt needs to be pulled down. Now we are going to talk about some specific strategies we use for ADLs. Backward and forward chaining are pretty similar, but let's start with backward chaining. So this is when the adult starts the task and the child only completes the last step. Gradually, the adult will do less as the child is able to do more of the task themselves. And this way, the child always gets the reward of finishing the task. For example, the adult will put the shirt over the child's head and help them navigate the sleeves. And the child will do the last step of pulling down the shirt at the hem. Forward chaining is essentially the opposite. This is when the child starts the task and the adults help with the later stages the child needs help with. For this technique to work, the child needs to be motivated to begin the task themselves. So you want to keep that in mind when first teaching the skill. You might want to start with backward chaining before you do forward chaining. For shoe tying, we can use larger objects like a jump rope to teach the skill of tying a shoe. So they can try practicing tying a rope over their legs. And this is easier because it's a gross motor activity. And children have a harder time with fine motor, so gross motor is a little easier. And once they master the skill on the rope, it's easier for them to translate the skill to their shoes because they already have the sequence memorized. We use a variety of visual markers, such as putting dots on shoelaces to show them where to hold them, or different colored laces to help them differentiate between them. You can use t-shirts with graphics to help the child identify which side is the front. You can use tags of a shirt to indicate which side is the back, but it seems often that they don't have tags on the back of shirts anymore. So if the parent is okay with it, they can put like a little Sharpie mark if that's okay. But if not, we'll find some other ways to do it. You can identify the front of the pants by looking for the zipper. The last technique we have here is the rolling of the shirts. Here, we're just rolling the hem of the shirt until you get to the sleeve. And we do this because it makes it easier to identify where the armholes are, and it decreases the chance of the child getting lost or tangled in the shirt. This doesn't work with slippery fabrics, so just something to keep in mind when you use this technique. So now we're going to get deeper into feeding strategies. We're going to talk about 3 in particular. So feeding is another ADL that individuals of this population find difficulty with, and that is because it's also a complex skill involving a lot of motor and a lot of cognitive skills. It's pretty normal for kids to demonstrate strong preferences or dislikes in foods, or perhaps not know how to independently use utensils up until around the age of 2. Once it's past that, we would start taking initiatives to expand their food taste as well as work on feeding independently. So today, like I said, we're going to be talking about 3 feeding strategies in particular: preparing preferred and non-preferred food, desensitization, and food chaining. So before I go on to talk about these strategies in depth, I do want to preface them by letting you know that each of these strategies are going to take some time. These are not changes that will happen overnight, so it's important for us to have lots of patience and to not give up when working on this. First, we're going to talk about preferred and non-preferred food. So this technique utilizes positive reinforcement and does not acknowledge negative behavior. Examples of positive reinforcement would be verbal praises, clapping, continuing interaction with them, or immediately receiving a preferred item. This just depends on what the child is most responsive to. We ignore the negative behavior because we want to take attention away from these behaviors. That is to say, the more attention you give a behavior, the more likely it is to be repeated. Moving forward, I'm going to refer to a non-preferred food item as NP, the letters NP, just because it's easier for me to say. So our first step here is to select an NP that is developmentally appropriate and similar to a food the child is already familiar with. We are then going to present this NP to the child once they perform the desired behavior, which we'll talk about, we immediately reward them with the preferred food. So some possible behaviors we would be looking for is looking at the NP, touching it, or holding it. The starting point just really depends on how averse a child is to this food. An additional thing you can do when using this technique is the token system. This is just a visual behavior chart that can help a child see their progress towards their goals. So for example, a child would earn 1 sticker on either paper or some sort of chart after each successful pairing of an NP and a preferred food. After they earn 3 stickers, they are then given an even larger reward, like a preferred toy. And as the child improves and begins to tolerate more, you can increase the number of overall trials to be completed until they receive the larger reward. So in the beginning, they needed 3 stickers, but as they improve, they're tolerating more. We want to challenge them a little bit, and we'll increase it to 5 stickers instead until they receive that larger reward. You can also pair this NP with a preferred drink instead of using a preferred food, or in conjunction with a preferred food. This can be more beneficial because it helps reduce the aftertaste. And that's really helpful for problem eaters because the aftertaste is what they find to be the most aversive. Over time, the NP becomes more tolerated. We would decrease the amount of sips that we're taking from that preferred drink. So like I said previously, it's important to have patience and to not give up when we are using these strategies. And I just want to underline that point again. When you're introducing a child to new food, it may take at least 10 successful exposures before the child can accept the food consistently. But don't give up, it's definitely possible, it just takes time. So the next one is desensitization. This is the process by which children are slowly and gradually introduced to a new food item, or NP. And we do this through decreased defensiveness and increased tolerance through repetition, rewards, and engagement. Here, we would first make a food list and a drink list of the things that the child tolerates well and the food that you want them to eat. You can organize this list by categories as well as properties of the food. So that could be texture, size, or color. NPs that are closely related to but have slight variations of food they already accept will have the most success. For example, if a child already eats yogurt, pudding would be a good food to start this process with. So you would begin this process of desensitization at times other than the main mealtime. This is because you want to keep the main mealtime a positive experience. If you start this process during main mealtimes, like you do this at lunch or dinner, they can start associating those meals with stress, and we don't want that. So we would do this process of desensitization during playtime, snack time, or perhaps during a telehealth session. At the beginning of this process, our first goal is to just have the child interact with the food, not necessarily have them eating that new food right off the bat. We want to create as many fun experiences with the food, such as feeding the non-preferred food to dolls or the individual who's there with them, counting or sorting the food, or using the food to make art and crafts. By having these positive experiences, it helps the child view the food in a non-threatening way, which is what we want. Once the child is tolerating the NP during play, you would then have them sit at the table with the food somewhere placed on the table. This is to get the child used to the sight and smell of the food in the area where they have their main meals. Throughout multiple sessions, and as the child gets more acclimated to the food, you can bring it closer and closer to the child until finally they can tolerate it on a plate in front of them without expectations to try it. At this point, you can have the child start to play with the food using their fingers at that table on that plate. And once they get used to that, you can work on them tolerating the food near their face, their cheek, their nose, and lastly, their lips. And when the food finally is tolerated at the lips, we can work towards the mouth. Sorry, I lost my place. So this can be done by first licking the NP, and then if it's tolerated, we would then work on biting into the food, then holding the food in the mouth for a few seconds before spitting it out, to finally then chewing the food and swallowing it. So as you can see, we're working in stages in order to get the child desensitized to the food and increasing their tolerance for it until it's consistently accepted. And once this food is consistently accepted, you can now add this to their main meals. You've successfully completed the arduous process of desensitization. So now we're going to get into our last one. So this is food chaining. This is the process of introducing new food to a child's diet by selecting items that have the same flavors or features as food the child already accepts. And because you're building on existing preferences, this approach reduces the chance of an aversive response, which is nice. So we start off again by creating a list of the food that the child eats consistently, and then we create a list or a chain of the items that have similar features such as the texture, the taste, the consistency, or the temperature. This process usually involves 4 levels that build upon one another, and we'll see how that process is in this example I have laid out. So another thing you can use during this process is sauces, dips, or condiments, and you can use them if you think that will help them tolerate the food better. And as the food becomes more tolerated, you can decrease the amount of sauce or condiments they use until they can eat it without anything, or any sauces. So now to get into this example we have here, we're going to use chicken nuggets as our base food. So we have a child who only eats chicken nuggets. And more specifically, they only eat chicken nuggets from McDonald's. We would start here at level 1, which is to maintain and expand current taste and texture. This could be trying chicken nuggets from other fast food restaurants, such as Burger King and Wendy's. getting them used to store-bought chicken nuggets, so like the frozen ones you can make at home, which are often healthier, a little bit. Or you can get them to try different sizes, such as chicken strips, chicken fries, or popcorn chicken. And that would all fall under level 1. So after they're consistently accepting the food from level 1, we move on to level 2, which is where we vary the taste but maintain the texture. So here we would introduce different flavors such as honey barbecue, Korean barbecue, garlic pepper, things of that nature. You can use condiments and dips as well if you think that will help that child tolerate that new flavor. Once they are consistently doing that, we move on to level 3, which is where we maintain the taste and vary the texture. So here we're finally moving away from fried foods. We're introducing grilled chicken instead of fried chicken. Here you can cut up the pieces of the chicken breast or the drumstick so kind of look like chicken nuggets, and that may help them accept that new level of food. And then lastly is level 4, where we vary both the taste and the texture. So at this level, you would introduce the child to food such as fish sticks, breaded pork chops, hamburgers, and popcorn shrimp. As you can see, just by changing the feature of an already accepted food, one feature at a time, you can bring variety to a child's diet. And this technique I like because it can be done with any food group. And just remember that you need to be patient and to not give up. So I just wanted to talk about, before we move to this next section, hold on. I wanted to briefly talk about ADLs and preparatory activities. So very often in the beginning of an OT session, we'll do these activities which work on organizing or warming up the individual's body through a variety of sensory-based activities. And we do this to prepare their body to participate, hence the name preparatory activities. This could be things like jumping, bouncing, or providing deep pressure. It just depends on what that child needs or craves. So for example, if we're working on feeding and the child presents with oral defensiveness, which is an unusual sensitivity to taste, smell, or texture, we'll often warm up their system by providing oral motor massage or perhaps use a Z-vibe. If you don't know what a Z-vibe is, this is essentially just a vibrating tool. It looks kind of like a toothbrush, and that provides tactile oral stimulation to decrease the defensiveness and help get them ready to eat. Prep activities are just a really great way to start off a session and get the child grounded in order to maximize their participation and increase their productivity. These activities are not limited to sessions just working on ADLs. I just wanted to mention it here just to kind of segue to our next topic, which is sensory.
So sensory is a very well-spoken, well-known topic when it comes to the autism population. So we're going to go into detail as to how sensory-based interventions look like. So from early age on, we all learned the 5 senses, which is vision, smell, hearing, touch. But most people do not know that we actually have 7 senses in total. So in addition to the 5 that I just mentioned, we have the vestibular sense, which is our body's perception in relation to gravity, movement, and balance. So this is basically us being able to tell where we are in space. And a perfect example is knowing when you are in an elevator, you're not physically moving, but you can feel yourself ascending or descending in the elevator. And we also have proprioception sense that lets us know where our body parts are and how we are positioned in space, and that allows us to help plan our movements. So a good example is if I close my eyes right now and I clap my hands, I'm able to have the target and clap my hands without having vision there in sight. And another example for proprioception can be when you're writing with a pencil, you tend to put too much pressure, the pencil breaks. So when you have proprioception, you're able to tell how much pressure you're applying on the writing utensil. So how does autism influence sensory? So we have what's called sensory integration, which is us basically organizing the sensation that we get within our body and the environment so that we can use our body effectively within the environment. So an example of sensory integration can be, let's say you're spinning for 30 seconds and you become dizzy. So we naturally widen our stance so that we don't fall. So that's an example of sensory integration. And our nervous system is composed of our brain, spinal cord, and spinal nerves. And the main function of the nervous system is to combine and synthesize the information that we're receiving and getting an overall big picture. So its specific function is sensory processing, where we receive, interpret, and organize the information from all the 7 senses that we just spoke about previously. And I do want to mention before I go into atypical sensory patterns is that we all have sensory preferences. It's not something that's just specific to children with autism or sensory processing disorder. For instance, I don't like heights. That's something that I've never liked. So I'm considered to be more hypersensitive with vestibular input. So the issue when it becomes atypical is when it completely stops a person's function in their daily life. So if I had a typical sensory pattern with vestibular input, I wouldn't be able to go up and down the stairs, for instance. And that's something that will impede my ability to move around my environment and do what I have to do. So now we're going to go into specific types of atypical sensory patterns. So we have sensory hypersensitivity. And this is when you have negative reactions to low levels of the environment stimuli. So an example can be you're putting on your shirt in the morning and you feel the tag in the back of your shirt. Most people will feel it or maybe not even notice it at all and go about their day. But a child that has hypersensitivity to this input, you may see them not even wanting to wear the shirt, crying, and very irritable because they feel the tag on their shirt. And sensory hyposensitivity is when you have a diminished or absence response to a stimuli. So when you take a bite of something that's hot, we have the natural reaction to blow, and sometimes you spit out the food if it's way too hot. If a child has hyposensitivity, they may continue eating the food and it's physically burning their tongue, but they're not reacting to the pain. So it can be very, very painful for the child to their tongue and their taste buds, but they do not feel the pain, and that can cause a big danger to themselves as well. So children that have sensory hyposensitivity, sometimes they're sensory seekers. So these are the children that they try to seek out that strong sensory input that they have, that they do not have. So an example of a sensory seeker may be a child who's in class and they're sitting down and then they just get up, they start running around the classroom, jumping up and down because they want more vestibular and more proprioceptive input. And just sitting down for long periods of time does not allow them to have that. So how do atypical sensory patterns present? So there's many different examples other than what I included in here. These are just some to name a few of how it may look if a child has an atypical sensory pattern. So first, it may affect their ability to complete hygiene tasks, such as taking a bath, brushing their teeth, maybe even going to the dentist. It may be very uncomfortable for them. It may also affect their ability to be in noisy, busy environments. So imagine yourself in a mall that's very packed. There's a lot of people, there's different fluorescent lights around. There's also different auditory input. You hear different stereos going on. You also hear children crying. Let's say you smell different types of foods around. And most people, it doesn't bother them. They go about their day, but this can really bother a child to the point where they start crying, they have an outburst. Sometimes they may even try to run away, which is very dangerous. So you have to be aware of what is being overly stimulating to the child. Also, going up and down the stairs can be a problem for a child that has vestibular hypersensitivity, the example that I use. The child can become very faint or dizzy going up and down the stairs, which again poses a danger to themselves because stairs are something that sometimes you just have to go up and down. Sometimes there's not an elevator around. It may also affect the child's ability to wear clothes. So not only the tag is bothering them, but sometimes certain textures of clothes, such as wool or let's say suede, may bother the child, which, you know, it's not a problem if they live down in Florida, but if they live in New York State like us, it's very cold in the wintertime. So exposing the skin to such cold temperatures can be very dangerous as well. And right here, I have a picture of a jungle gym in a park. So basically, you see that there's a bridge right there that's connecting one side to the other. And it's used, you know, for the child to go from one side of the gym to another side. But a child who's maybe vestibular seeking may be actually hanging off the bridge, which is not the way that it's intended to use. So the child can fall, hurt themselves, or actually fall on another child. So that's something also to be aware of. So now we're going to talk about specific strategies that you can use for sensory or other sensory-based strategies. So we already spoke a little bit about desensitization. So to go build off what Eliza has spoken about, desensitization reduces the hypersensitivity that the child may have by grading the exposure to the types of sensory input as sensitive areas. So an example would be someone who is sensitive to touch, for instance. You want to start off with a texture that is dry. So an example would be uncooked rice, uncooked beans, or breadcrumbs. And this is a texture that it's not going to leave residue on the hands, it's just going to fall off. And then you're going to work towards a semi-wet texture. Semi-wet texture would be something like kinetic sand or moon sand. And this is basically a texture that if the child touches it, they can feel it, you know, it gets stuck together to the hands. But again, it's not something that's going to stay on for a long time. They could just like rub off. And then we will progress to a wet texture, which will be liquid, such as water. After that, you will move on to sticky, wet textures. So a good example of that would be shaving cream. So shaving cream is a texture that once you put on your hands, it's not going to go anywhere. It's just going to stay there. And you can use shaving cream to play with toys, have them find things, write their names on it. Maybe take a toy car and go across. And we also have the sensory diet. Sensory diet is basically whatever sensory experiences that the child has that's specific to them. We're going to try to give them that input to try to support them in calming or alertness. So an example of a sensory diet can be for school. They jump on the trampoline. Once they get to school, they write. After they write, they get a break that they get to go on a swing. And then let's say after lunch, they get to wear a weighted vest for 30 minutes. And that can be a sensory diet. So it's basically just like a schedule of when they get these inputs. And now we're going to speak about the specific strategies that you can use. We have weighted vests. And a weighted vest is a vest that's going to be 5% of the child's weight. And they have different styles and different colors. And they basically have to use it at a set schedule. So it's not something that they will wear for the whole school day. It's something that they have to wear periodically because our brain tends to habituate, which is get used to a type of sensory input. And basically once our brain is getting used to the weighted vest, it loses its effectiveness, and it can be very good for calming the child as well. And we also have the move and sit cushion. So we have an image right here of the little boy sitting down. And this cushion is very cool because the child can sit in class and have the ability to move around, but still stay seated. And sometimes they have nubs that come out of it, so it gives more tactile input to the child as well. We have the brushing protocol. So right here, I also included a picture of brushing, and the child can do it themselves or their parents can do it. And it's basically used to give more tactile input. This can be for hypo or hypersensitive kids to tactile input. We have swings, we have different types, net, bolster, or platform. And I will include a picture of those and go more into detail. And caregiver education is always most important because you want to tell the parents what the child is experiencing and help them try to understand their child's sensory needs and how to read off when a child needs those needs to be met. Also, collaborating with teachers is most important as well because the occupational therapist can tell the teachers, listen, this child cannot be seated for long periods of time. They need to have breaks in between their classes, or teachers can tell the occupational therapist that they see any progression, or maybe there needs to be more things that we have to work on in therapy. And we also have something called self-direction. So it's basically having a balance of structure between the OT, but also giving freedom of choice to the child. So let's say we have a child who is vestibular seeking. The OT can ask the child, hey, today, do you want to go on a swing or do you want to go on the trampoline? That way the child has the decision to pick what they want to do, but it's going to meet their needs, whatever they pick. And we also have active participation. So active participation is basically our brains learn best when we are actually participating in an activity versus it being done to us. So let's say we have a child who is vestibular hypersensitivity and they can't handle the vestibular input. It's best if that child pumps themselves on the swing, so pushing themselves rather than somebody pushing them from behind. So right here we have some images that I wanted to show you guys. So we have the weighted vest right here. And like I said, there's different styles and different colors. They have denim. They also have winter looking vests as well. So it can be discreet, and also it can be wear over clothes or under clothes, you know, depending on what the child and the parent wants as well. We have the platform swing right here. So this swing is best for children who are vestibular hyposensitive, so they don't like that much input. So you're trying to grade them and get them towards higher input. So this is great because the child can actually sit down and have their feet touch the ground, and they can swing themselves but not have that loose control from the swing. We also have the net swing. The net swing is great because it provides additional tactile input. So, you know, having that blanket feel on the child can actually be very calming, and it can be great for children that want to have more vestibular and tactile input as well. And we also have the bolster swing, which is the last swing here. And this swing offers the most degrees of freedom. So the child is going to move the most, and this can be very helpful for children that want more vestibular input. They can also sit like the little girl is in this photo, or they can hang off of it like a monkey. There's different ways that you can use it, and it's very fun. And I also want to mention that with desensitization, it's something that's going to take a while, like Eliza mentioned. Sometimes you may have to regress back if a child is having really bad reactions to a different type of sensory input. So you just have to be patient, and it can change as well.
Hello, I'm back. Now we're going to talk about some visual motor and perceptual skills. First, we're going to define them. The visual motor integration is the coordination of visual input and fine motor control. This allows us to use our eyes and our hands in an efficient way. Examples of this is writing, coloring, tying shoes, or any type of sport. It's also commonly referred to as hand-eye coordination or eye-hand coordination. They're all the same thing. So we're going to get into visual perception, which is how the brain interprets what the eye sees. There are 6 of them that we're going to focus on here. The first being form constancy, which is the ability to recognize and label objects even when they're viewed from different angles or different environments. An example of this is being able to recognize a dog is a dog, whether you see it in a photo, laying on your couch, in the park, and you can tell it's a dog whether it's sitting, lying down, or running. Next is figure ground. So this is the ability to focus on one specific piece of information in a busy background. This is useful for finding a sock in a messy drawer, finding your parents in a busy crowd, or perhaps finding a similar colored item from a similar colored background, like a green button in the grass, although I don't know how common that is. Visual closure is the ability to correctly perceive an object or word, even when it's partially hidden. So that's being able to make sense of a word, even if it's a little bit smudged, or recognizing an object even when you only see part of it, like a road sign being blocked by branches or a building. There's visual discrimination, which helps a child see subtle differences between objects or pictures and to see if something matches up. So this could be distinguishing between different type of coins, like the value, so 1 cent, 5 cent, 10 cents, or between different currencies such as American and European, or matching socks with different colored patterns. Spatial relations is the ability to perceive two or more objects' position in space relative to oneself and in relation to each other. So for example, you're asking a child to get something from the desk over there in the corner. The child has good spatial relation skills if they're able to retrieve that item without bumping into anything. Lastly is visual memory. It's pretty self-explanatory. It's the ability to recall or remember visual details of what you have seen. That's like learning sight words, recognizing letters and numbers, and then copying work from the board or a book. So how do visual, motor, and perceptual problems present? It can affect all these abilities I have listed here: reading, writing, navigating their environment, cutting, doing crafts, playing games, and like dressing. Some specific manifestations are letter reversals, such as vertical or horizontal, confusion of similar looking words, excessive squinting or blinking, not being able to write on a line. They're always going a little bit above or a little bit below. Navigation difficulties, as I said before, and inconsistent or poor sports performance. That's because they have a problem with either the visual motor component, the perceptual component, or a little bit of both. So what do we do? How do we work on these skills in a telehealth format? A lot of things are free online. There are a lot of worksheets. There's a lot of websites. So that's really great for us. We can use tracking tools such as a ruler in real life or the cursor of an on-screen text window when you're doing telehealth. And this helps the child maintain their place without getting lost. We can enlarge the print. So you can do so by buying larger print books or by using a magnifying glass. If it's on a computer, you can zoom into the screen or enlarge the font size, which is very nice. And we can even use different types of paper, which Julie will talk about later in the fine motor section. We also do a lot of drawing activities in our interventions to work on visual motor skills and visual perceptual skills. So a lot of the times we'll start off drawing vertical and horizontal lines because those are first in the developmental sequence. We then work on drawing geometric shapes such as squares, circles, and triangles. And these drawing activities work on the pre-writing skills needed to successfully learn how to write letters and numbers, which again, Julie will talk about more later. We use mazes and puzzles as well to work on eye-hand coordination, problem solving, form constancy, discrimination, and closure, just to name a few. If the child has difficulty completing a maze, a lot of the times we'll have a child go through the maze with their finger on the screen. So just mapping out different routes to see which one works. When working with puzzles, we can teach the child strategies such as creating the borders first before doing the middle, or looking at the completed puzzle completed picture of the puzzle. There's usually a visual representation there if you're doing it online. And if you're watching them doing the puzzle in person, there's usually the box, so you can use that as well. Stringing beads is something we do a lot to work on spatial relation skills as well as visual motor integration. You can add a visual discrimination and memory component as well by having them copy a specific color pattern with the beads. You can also modify this task by using a pipe cleaner because they're more sturdy, or you can use beads with bigger holes or perhaps a wider string, whatever is most readily available to them. We also use coloring books, connect the dots, color by number worksheets, all types of worksheets. They work on a variety of visual, perceptual, and visual motor skills. For example, sequencing, figure ground, and visual motor skills. When we use these worksheets, we like to focus on their ability to control their movements, to color in an allotted area, as well as their grasp. But again, Julie will talk about this more later. When possible, we like to do as many of these activities in prone or lying on their stomach. And this is because it helps develop shoulder and neck stability and promotes the head remaining in an upright position. Visual motor and perceptual skills are often worked on in conjunction with fine motor skills. So Julie will go into greater detail about some of those things you touched on here.
So we have fine motor based interventions that we're going to go into detail right now. So we're going to start off with hand function. So we learn hand function developmentally from infancy all the way until early childhood. So first we learn reach, where we're going to extend our arm away from our body to try to grab an object or place an object somewhere. We have grasp, which is holding an object in your hand. We have carry, that is basically transporting an object from one hand to another hand or from one hand to another placement. There's voluntary release, and voluntary release is basically holding an object in your hand and you're extending your fingers like this and it just drops. We also have in-hand manipulation. In-hand manipulation, there are 3 different skills that I'm going to speak about right now. So first we have translate. So this is basically moving an object from the palm to the fingers or the fingers of the palm. So I'm going to show an example right now. So basically I have a penny right here and I'm moving it from the palm to my finger, and then I could do it the other way around. And this is very important if you're trying to grab change from your pocketbook or let's say your pockets, and you can get something from the vending machine. We have also shift. So shift is going to be moving an object between the fingers. So shift can be very useful for when you're trying to use a pencil, let's say. And let's say I grab the pencil like this, I can shift my fingers down so I can start writing. Shift is also important for playing cards or counting money, which we all like to do. We also have rotation. So there's 2 different types of rotation. We have complex and simple. So a complex rotation, I'm just going to put my webcam down so you can see. So first I'll start off with simple. So simple would be rolling an object between the fingers. So let's say I wanted to grab this pencil right here, right? So I grab it like this. This would be a simple rotation. And then we have complex rotation, where so say I have the pencil like this, and this is turning an object over between the fingers. Let's say I'm writing. So I just did shift right now, I'm writing. Or I made an error, so let me erase. So I can do complex rotation to use the eraser and then go back to using my pencil. Then after in-hand manipulation, we have bimanual skills. So bimanual skills is basically using 2 hands at the same time so you can complete an activity. So this will be important when you're zippering up a jacket, let's say for instance, you need to use both hands to be able to do that. And hand functions are basically very related to sensory, which is why we had sensory first. Basically, imagine you don't have any good touch receptors in your hands, you can't really feel much, it's going to be very hard for you to be able to move your fingers and use the right motor control. And the same thing goes the other way around, where if you don't have good motor control of your fingers, it's going to be very hard for you to feel things with your fingers, for instance. And basically, within our hands, we have many muscles, and we also have muscle functions. Most people tend not to think about our hands being muscular, but we have a lot of hand muscles. So we have muscle strength, which is, some have more strength than others, some are weaker than others. We have muscle tone. And muscle tone is going to be very important because that's going to be maintaining a partial contraction to be able to do something. So it's not forceful. So right now I'm sitting up straight and I'm using my back muscles so that I can keep this posture. But if my back muscles relax, I will be slouched over or can't even maintain myself upright. And for hand function, for instance, I have this pencil in my hand. I'm not doing anything forceful. This is not heavy at all, but my hand is partially contracted to keep this in my hand. If I had low muscle tone, it would just fall off my hand. I wouldn't be able to hold anything. And we have muscle endurance, and this is basically how long you could keep your muscles contracted. So let's imagine a kid is in the library and they're trying to check out books, and the books, they have to, maintain a certain amount of grip strength in their fingers. And if the books are heavy and they don't have good muscle endurance, they may not be able to make it to checkout. So that can be an example as well. So there's different types of grasp patterns. We have many different types to grab different objects. We also have different grasp patterns for feeding utensils and writing utensils. So first, we're gonna talk about the left image right here before I go on to the right. So the left images, we're gonna look at letter A. That's called a cylindrical grasp. It's very important when grabbing, let's say, a cup of water or a bottle of water. We have the letter B, which is the spherical grasp, very important for holding on to round objects like balls. We have C, which is the hook grasp. And the hook grasp is very important if you're holding on to shopping bags or, let's say, a purse, or even the bus handrail. They have the hook there, you have to hold on to it. That's a hook grasp right there. And we're gonna go to the right side now. So letter A, that is called a tip-to-tip prehension. So this will be very important for holding on to very small objects, such as small beads, or let's say a needle if you're trying to thread. Letter B is pad-to-pad precision. So this is very important for holding on to a coin, so right here. We also have letter C, which is pad to side prehension. So this is the thumb pad going to the side of my index finger, and it's very important for holding onto your key. So I have a key right here. I'm just gonna give an example. So I use this to get into my house. Most people do not know that you actually learn how to use scissors developmentally. It's a sequence to it. So first, at the age of 2 years old, a child may be able to snip with scissors. And then at the age of 2.5, they may be able to cut across a 6-inch piece of paper. It's not so much to say that they're gonna follow a line, they're just able to cut across. We have from ages 3 to 3.5, they may be able to cut on a line that's 6 inches long, so actually follow a line. From ages 3.5 to 4 years old, the child may be able to cut out a circle. And I also want to note that research suggests that circles are harder to cut than squares because of the rotational aspect to it. But from ages 4 to 5, they may be able to cut out a square. And then from ages 6 to 7, they may cut out a variety of shapes, such as coloring book pages, or let's say superheroes or princesses, whatever the child likes. So right here at the blue scissors, we have standard school scissors, but at the right side, we also have these red scissors. These are adaptive scissors. Their official name is loop scissors. And this is great for beginners who are starting to cut, that have weakened finger strength, or they do not know the motion of cutting. So these scissors are very cool because they're self-opening. So when you snip, they're automatically gonna cut, open back up, and the child does not have to snip and open, snip and open. Once they snip down, the scissors are gonna open. So this is a great starting point for children that are starting to cut. Okay, so first I talked about hand function in general, but now we're gonna go specifically into handwriting, as this is a fine motor skill as well, but it happens after hand function, so that's why I did that first. So basically the requirements for handwriting, you need to have lower level perceptual motor processes and higher level cognitive processes. So specifically perceptual motor processes are vision, perception, auditory, and visual motor integration. So an example of visual perceptual is being able to copy from a board onto a piece of paper. And then for auditory is basically actually being able to hear what notes are being dictated to you. And for visual motor integration, this is basically combining different types of components to write. So being able to use the paper and fix it to yourself, being able to use the pencil and have the proper eye-hand coordination for that. Cognitive processes are executive planning and working memory. So executive planning will be very helpful for kids that are older. So let's say they have to write 250 words, they'll be able to plan exactly how many words to incorporate and how much detail they want to put in, and visualize the space that they have. Working memory is going to be important also for older kids who are getting notes dictated to them or having to take notes. So let's say they're copying notes from the board, they see a sentence there, they're able to remember it in their head as they're writing the sentence instead of having to constantly look up from the board to their paper. Language processes are important because it's basically the child's ability to hear a word and identify the letters in it. So let's say the word cat, a child's able to hear the letters C-A-T in the word cat. And visual motor integration is the strongest predictor of handwriting legibility. So this is how neat the handwriting is. So handwriting difficulties, we have different types. So the first can be immature pencil grasp patterns. And I'm gonna go more into detail the next slide of what an immature versus a mature grasp pattern looks like. We have visual memory impairments. So this is a child's inability to imagine a letter or a word in their head, how it looks like when they're writing. Visual discrimination. So basically, this can be an example of a child not being able to recognize letters that are in different fonts. So right here, if you look into the slide, we have lowercase a's. We have two of them, but they look different. So the child may not be able to recognize that those are both letter A's. Visual spatial awareness. These may present as children who tend to reverse letters, such as the lowercase m, the lowercase w, or even the lowercase b, the lowercase d. Tend to see that a lot in kids. We have figure ground issues. Figure ground issues, you're gonna see it more for older kids. So this may be a teacher assigning children to take notes from pages 5 to 10, for instance, and a child with figure ground issues, they may not be able to point out what is important from pages 5 to 10. So they may literally try to write every single thing from pages 5 to 10. So this is the developmental sequence of grasp. So first we have the cylindrical grasp, which is holding onto a writing utensil like this and using it to write. When you have this grasp, you tend to use more shoulder movement instead of the fingers itself. So it becomes very painful, it's inaccurate when writing, but it's very common in beginners in writing. We have the digital grasp where you have a pronated wrist, so your wrist is facing this way. So you're holding onto the writing utensil like this. And again, you're still applying a lot of pressure when writing. You can't be as accurate and you're still using a lot of your shoulder movement. The modified tripod grasp. This grasp can be functional, but it may not have the best legibility. So that is the neatness of it. But this is great for kids that are trying to progress to a more mature grasp. We have the tripod grasp, which is the most mature grasp. And then right here on the right, we have dynamic tripod, dynamic quadrupod, lateral tripod, and lateral quadrupod. So I will break it down right now. So a dynamic tripod grasp is when you're holding onto a pencil and you're incorporating your thumb, your index, and your middle finger to grasp the pencil. And it's called dynamic because you're moving these 3 digits to write. And we have the dynamic quadrupod grasp, which is basically the same as a tripod, but it's called quadrupod because you're incorporating the ring finger as well when you're holding onto the pencil. We have lateral tripod, where the pencil is tucked in the webbing between your thumb and your index, so it would be right here. And this would be lateral tripod, you're writing. And lateral quadrupod is the same as the tripod, except you're incorporating your ring finger in it as well when you're holding. And basically, these types of grasp patterns are functional because it's not going to cause cramping in the hand. I mean, it can if you're writing a bunch, but for typical writing in the class session, you're not going to have cramping. So it's very important because it also helps with the legibility of your writing. It may also explain why there's different types of handwriting and penmanships between people as well. So how do issues in hand function present? So we're just going to talk about hand function in general and also talk about some fine motor skills with handwriting as well. But you may see a child playing with a toy that is different from the way that it's intended. So right here we have a child playing with toy trains, and they're supposed to grab it and roll it around and play with it, maybe connect some pieces. But this may be the child that you see that is throwing the train on the floor constantly, or they're banging it on the table because they're not able to grasp it the way that it's meant to be. These may be the child that they're not able to complete activities of daily living without help. So this may be the older child that is still asking for help from a teacher or from a caregiver to be able to unbuckle their pants, or maybe even grab toilet paper. It may be hard for them. Maybe even to squeeze toothpaste. They may have weak muscle strength where they can't actually do that movement. It may hurt the child to write in color, so they may cry, they may avoid these writing activities because, as you see in this image of the little boy with the pencil, he's holding it with a gross grasp, and eventually that's going to cause cramping, especially if he's writing and coloring a lot. He may have tried to avoid it. And this may also be the child that they have an assignment to do. It's supposed to take 30 minutes to do, but they're at it for an hour and a half because they have a hard time grasping the pencil. They have a hard time writing because, again, they have the wrong grasp patterns. So that may be another sign. But again, there's more signs out there, but these are just some to name a few. So interventions and strategies for hand function in general. First, OTs love to have the 90-90 rule, and this is basically having a great sitting posture where the pelvis, the shoulders, the feet are at a 90-degree angle, so you're sitting up properly. And it's very important because let's say if a child doesn't have great seating posture, they're going to constantly focus on fixing themselves and adjusting themselves rather than focusing on the hands. So you always want to have the best proximal stability to have distal mobility. So it's also very important to note that you want to have chairs and tables that support the child. So you don't want to have the child sitting on a table that is too low for them or too high for them. You want it to be a great length for them. And the chair has to provide support for the shoulder, pelvis, legs, and the feet. Okay, now we have therapeutic. Therapeutic is very, very popular in occupational therapy, not just in the pediatric population, but also in the adult population. Therapeutic is very amazing because it's similar to Play-Doh, but it's a more rigid material where it can stretch. It can work on finger range of motion. It can work on strengthening, and it has different levels. The levels are categorized by different colors. We tend to use a lot of the red therapeutic, which is soft therapeutic, that's very good for children. And basically the child can use it to manipulate it. They can pull it apart. They can use it and extend their fingers in it to have more range of motion. You can even make it fun and hide objects in it, such as pennies or beads inside it. It's very fun. Kids tend to love it. And we also have occupation-based activities. So this is basically looking at any occupation that the child has to do and, try to make it fun for them. Kids, we always try to make the therapy sessions as fun as possible so that it feels as though it's not a burden to them, but we also have them working hard. So let's say you wanted to work on voluntary release. You can play Connect 4 because you're still working on having that lateral pinch grasp to hold onto the objects, and also you're keeping track on where you want to place the objects as well, and voluntary releasing. If you want to work on shift and finger dexterity, you can play shuffling card games with them. If you want to work on in-hand manipulation skills, let's say you wanted to work on finger to palm, palm to finger, you can have them hide pennies in their palm and put them in a piggy bank. You can just do different types of ways to make it as fun as possible for the child. Now, specific interventions for handwriting. Handwriting without tears is very popular with OTs because this is an award-winning program that emphasizes the frequent feedback that children are able to have so they could self-evaluate their writing and regulate how they're writing. So right here, we have an example of handwriting without tears paper right here. This is the top picture with the grids as well as the left picture with the lines. And basically, the picture with the grid is good for children that have spacing issues because the grid box tells them where they can put in the letters in. And also the lined paper is great for kids that have a hard time keeping within the lines when they're writing. And we also have highlighted paper. This is not handwriting volunteers, but this is something that an occupational therapist can do, a parent, a teacher, anyone can grab lined paper and grab a highlighter, highlight where they want the child to keep their handwriting in, and it can be a great visual feedback for them. We have pencil grips. Pencil grips are great because they're easily accessible, they're affordable, you can buy them anywhere, and you can use them to try to help the child have a great tripod or quadrupod grasp. And also writing with jumbo markers or short crayons can be helpful as well, because it would try to force the child to get out of immature grasp and try to use the more proper grasp. And as Eliza mentioned earlier, we like to do activities in different positions. So the prone activity for writing is best for children who use a lot of shoulder range of motion. So if the child is lying on their belly, they have stabilization of the shoulder, and they're able to move their digits more than their shoulder when writing. Wrist extension is also important for the child that has the digital grasp that we spoke about, that their wrist is pronated like this. When they have wrist extension, it facilitates a better grasp. So you can do wrist extension by having them write on a chalkboard or a dry erase board. So it will force their wrist to be in this position because they have to hold the writing utensil up this way to write. And also writing on a slanted surface, so it can be a book, like a textbook that you have slanted, or you can have like a laptop case holder. You can have that, the child writing over it, or even like a clipboard, for instance. So it's going to still try to have the wrist go in an extended position like this. So all the strategies that we just spoke about, it can be used for face-to-face therapy and also telehealth therapy as well, but we're going to speak a little bit more specific about telehealth techniques that can be used as well. Okay, so in face-to-face therapy, interventions are considered parent-mediated interventions. So these are considered parent-mediated interventions because the child works with the OT at school, right? And the parent's not in school. The parent, yes, of course, they can get feedback. They can speak with the therapist and find out what's going on, but it's basically the OT saying, hey, this is what we're working on in therapy. Can you please practice this at home? Basically, occupation-based coaching is different because it focuses on increasing positive child caregiver interactions. This can occur by the OT identifying the goals that meet the family's needs. This is basically the OT and the parent working together to generate solutions. And it also creates opportunities for practice in family activities and routines. So it's something that it's already built within their day and their typical routine. It's not something that they have to do, outside of their time or find additional times for it. So that's why occupation-based coaching is a little bit different. So the 5 key principles of occupation-based coaching, we have authentic contexts. So we already spoke a little bit about natural environments for children, but this is very great because this is going to be in, the interventions are going to take place in the daily places where family and the child are at all times. Family interests and routines are targeted because the OTs are going to support the caregivers to create strategies that occur within their normal routine and their interests that they have. The caregiver interaction and responsiveness is going to be positive because the OT is going to support that child-parent relationship to foster more strength in their bond. We have reflection and feedback. So the OT and the caregiver are going to discuss ways to increase the child's participation and evaluate the effectiveness of the strategies that is going on. Joint plans are basically the OT and the caregiver are having homework where they're working in between sessions and how to address the family's goals. So the caregiver may keep track of how much non-preferred food the child is eating, for instance, and then tell the OT, and the OT is doing research on different types of foods that the children can add to their diet. So we actually have a research study example on occupation-based coaching where 17 families of children with autism spectrum disorder participated in a 12-week therapy session via Zoom. The age of the students that participated were between the ages of 3 and 4 years old. So first, the OT completed a routine-based questionnaire to try to understand the family's daily activities, what is the basis of the initial session, and try to identify goals with the parents. So each family in the study identified 2 to 3 goals. Some examples included social interaction, self-regulation, which is the child basically able to regulate their own emotions. We have safety in the home and community, which is very important because, like I mentioned previously before, some children tend to be overly stimulated and they have a habit of trying to run away. So this was also another goal that was targeted in the study as well. So the results from the study that were found were that children's adaptive behaviors increased. So not only just in the home, the child was being able to act a certain manner, but you saw it carry on in different settings, such as the communities or in the school. And the parents' efficacy and their own skills and understanding their child increased because of collaborating and receiving feedback from the occupational therapist. They also saw a successful delivery of services. Despite being on telehealth, it was still great progression towards goals. And the children's participation in daily activities increased. More specifically, how often they were playing increased, as well as their skill development increased. So now we have a demonstration of telehealth interventions that we want to share with you all.
So I'm going to try to go a little quickly just so we have time for everybody's questions at the end. So first we have ADL interventions demos we would like to show you. Our first one here is called the coat flip method. This is a video showing a different way to put on a jacket if they have a problem doing so. So here they have to stand near the tag or the hood, put their arm through the holes, and then flip the coat over their head. This also works with button-ups. I like this method because there are less steps involved and it's easier to identify where the sleeves are. Next, we have an example of backwards chaining.
Now let's look at how to
wash hands. Okay, we're gonna turn water on, get soap, rub hands, scrub, 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 rub, rub, rub. Excellent, water off. Great job, your hands are all clean now. Here's your fruit treat.
So here the adult initiated the task and provided hand over hand assistance until the last step, which is where the child wiped their hands. And after the child completed this task, they were immediately rewarded with a reinforcer, which was a snack. Here we are going to do a sensory and visual motor and visual perceptual based intervention.
All right, so Allie, this is the first thing that we're going to draw. Can you see this on mom's phone?
Yeah.
Okay, so we're going to start at the top, and we're going to go all the way down to the bottom of your pan, and then all the way across. So you're going to try and fill that full space of your pan. So let's see if you can. Okay, hold on, wait, yeah. Beautiful.
So here we have a multi-sensory approach to working on these skills. They're using flour to practice creating the horizontal and vertical lines, which provides tactile feedback. We also have a visual model drawn right here on the screen, and the OT coaches the child step by step. So this is an example where we use tactile, visual, and verbal feedback to help the child progress and work on the skill. Lastly, we have a fine motor one. So hold on while I get this ready.
So I also want to note that this is actually an example of Handwriting Without Tears, the program that I spoke about with handwriting skills. And if you are interested, this video also shows the online program of Handwriting Without Tears, which has been available for parents to use at home. So it's been very beneficial during these hard times.
And F. Here we go. Let's trace F at the bottom. So first we find the smiley face. Good. Big line down. Then what? Jump to the top. Little line over. Little line over. Good job. Now let's go to the next one, but let's make the next one green. So flip it around. Flip your crayon. Oh, you're supposed to put this hand behind your back. Ah! That's okay. You got it on green? Wait, we got to get it back on green. There you go. You got it. All right, now hold your paper. And we're going to make one line down, big line down, and then jump like a frog. Boing. Good, and then little line over. Little line over. Okay, now we're going to do it again.
All right, I could watch that all day. It's super cute. But here's an example, like Julie said, of the Handwriting Without Tears program. So the OT is, again, coaching the students step by step throughout the entire process. If you heard the OT say in the beginning to find the smiley face when the student started drawing the letter, that was a visual prompt in order to show where the student should start their letter. When the OT asked the student to flip the crayon around, it's to allow the student to practice in-hand manipulation skill of complex rotation, which Julie talked about earlier. And he also reminds the child to keep their hand behind his back so he can't use it as an assist. He uses phrases like jump like a frog in order to help the child remember the sequence of the letter. And so there's a lot of little things happening in order to help this child remember the sequencing of writing a letter. So check this out if you can. It's a great resource.
Now we're going to speak about the future of telehealth beyond the pandemic. So the American Occupational Therapy Association, also known as AOTA, has been advocating to make OT services via telehealth to be permanent beyond the pandemic. And they're doing this by petitioning Centers for Medicare and Medicaid Services to retain access to services. They're also pushing for permanent telehealth coverage from other payers, so insurance companies that are private, such as United Healthcare and Humana. And they're also reaching out to smaller regional payers, large employers, and targeted state Medicaid plans. So we have the American Occupational Therapy Association really trying to make these services permanent for families due to the good feedback and the great outcomes that are happening for children during these sessions.
And now we're finished. So now we have time for your questions. So let me exit out of here and we can all look at each other.
All right, I'm gonna kind of facilitate the discussion on this. Excellent presentation, ladies. This has been a lot of really just wonderful information, and from all the comments and the feedback and questions I'm receiving, you know, you guys are really doing a wonderful job. So I wanted to first go back to one of the first topics that we touched upon, which is differentiating between OT and PT. So there is a question that asked, is it true that PT focuses more on the lower body and OT focuses on the upper body? So what do you guys have to say about that?
Well, how that often looks like the case, but in reality, OTs can work on all parts of the body. It just tends to just work out the way in terms of billing because we can't cross bill. So it usually just ends up that way. But in reality, we can work on whatever part of the body.
Yeah, I mean, I think that there's a lot of overlap, kind of similar to what you were saying between the two disciplines. I mean, we work on many of the same conditions and we have similar goals. I think the focus for PT is more on the biomechanical part of it. So working on more movement, strength, range of motion, things like that. And OT aims to focus on those similar ideas, but in the form that we're working on daily activities. as well. So it's always bringing in the activities of daily living components so that it's functional for our clients. And it's not just that they're able to physically do the motion, but do it in relation to an activity.